Good morning. We'll get started. Thanks for being here this morning. I'm Holly Brenner, the Vice President of Strategic Development and Marketing for our system. I really appreciate that you're here. Welcome to the new faces and welcome back to everyone else. We'll start with a reflection. This is called The Carrot, the Egg, and the Coffee Bean. A young woman went to her mother and told her about her life and how things were so hard for her. She did not know how she was going to make it and she wanted to give up. She was tired of fighting and struggling. It seemed that as one problem was solved, a new one arose. Her mother took her to the kitchen. She filled 3 pots with water and placed each on a high fire. Soon the pots came to a boil. In the first she placed the carrots, in the second she placed the eggs, and in the last she placed the ground coffee beans. She let them sit and boil, and without saying a word. In about 20 minutes, she turned off the burners. She fished the carrots out and placed them in a bowl. She pulled the eggs out and placed them in a bowl, and she ladled the coffee and put it in a cup. Turning to her daughter, she asked, "Tell me what you see." "Carrots, eggs, and coffee," the young woman replied. The mother brought her closer and asked her to feel the carrots. She did and noted that they were soft. She then asked her to take an egg and break it. After pulling off the shell, she observed the hard-boiled egg. Finally, she asked her to sip the coffee. The daughter smiled as she tasted its rich aroma. The daughter then asked, "What does it mean, Mother?" Her mother explained that each of these objects had faced the same adversity, boiling water, but each reacted differently. The carrot went in strong, hard, and unrelenting. However, after being subjected to the boiling water, it softened and became weak. The egg had been fragile. Its thin outer shell had protected its liquid interior, but after sitting through the boiling water, its inside became hardened. The ground coffee beans were unique, however. After they were in the boiling water, they had changed the water. "Which are you?" the mother asked her daughter. "When adversity knocks on your door, how do you respond? Are you a carrot, an egg, or a coffee bean?" Think of this. Which am I? Am I a carrot that seems strong, but with pain and adversity, do I wilt and become soft and lose my strength? Am I the egg that starts with a malleable heart, but changes with the heat? Did I have a fluid spirit, but after a death, a breakup, or a financial hardship, does my shell look the same, but on the inside am I bitter and tough with a stiff spirit and a hardened heart? Or am I like the coffee bean? The bean actually changes the hot water, the very circumstance that brings the pain. When the water gets hot, it releases fragrance and flavor. If you're like the bean, when things are at their worst, you get better and change the situation around you. When the hours are the darkest and trials are their greatest, do you elevate to another level? How do you handle adversity? Are you a carrot, an egg, or a coffee bean? Today we have with us some of our providers from the Agnesian Cancer Center. They're here to talk to us about some of the new things that are happening over there, and also, I believe, to introduce one of our newest providers. So with that, Dr. Vander Kooy.
Thank you for allowing me to speak today about radiation oncology and the new things we have at the Cancer Center as far as radiation oncology and the exciting new tools we have for radiation therapy treatment. I'd like to, first of all, introduce the people in our great department. We have phenomenal people in our radiation oncology department, and I've been here a little over 15 years, and it's all about the personnel. We have wonderful equipment, but it's all about the personnel. And I would like to introduce, first of all, Dr. Philippe Troicki from Hahnemann University. He joined us just recently. We're blessed to have Dr. Troicki join our cancer team. He brings a lot of experience and knowledge and compassion from Hahnemann University, and we're really happy to have him. So the physicians, myself, Dr. Kritko, and Dr. Troicki. We also, in the radiation oncology department, we have quite a team. We have an excellent team of therapists, Noel, Ellie, Bonnie. They're kind of the foundation of our team because I set up the treatment with the help of the physicist assistant and physicist, but they deliver the treatment on a daily basis. And here's 2 other therapists, Brian and Angie. And then many of you probably talk to our nurses when you call over for a consultation or if there's any issues as far as follow-up or ongoing care. Stacy is primarily Dr. Troicki's nurse. Tammy's primarily my nurse. And then Mary is primarily Dr. Kritko's nurse. And then the foundation of our team is we have an excellent physicist assistant, Phil Bowen, who's actually here today. He does all of the treatment planning on all of our patients. So I'll kind of explain when I set up treatment, when I simulate the patient or set them up. He helps me come up with certain treatments, whether it be IMRT or SBRT or 3D, some real conformal treatments to treat the tumor and minimize treatment to normal tissue. So Phil is a huge player on our team. And then Tim Lamont does he's our physicist. He does all the quality assurance and double checks all my work and Phil's work, and he's phenomenal. And then our leader of our radiation oncology team, Heather Bowen, she's here. She does a phenomenal job with the entire team coordinating everything. And of course, we are blessed to have an excellent ancillary staff. We have Chris Blonigan, she's here in front. She's our oncology navigator. She follows a number of the patients from diagnosis onward to make sure they're worked up properly. We have Liz, this is actually incorrect, it's not Liz H, it's actually Liz Gorecki. She's just recently married, our dietitian. And she's very helpful on all of our head and neck cancer patients, our gastrointestinal cancer patients, where we really need nutritional support. And last but not least, Christy, our social worker, who does a phenomenal job with patients, finding resources for patients, helping patients with disability paperwork, finding rides for patients. She's just an awesome member of our team, and many of you probably talked to her also. Now, as you may know, the name of our cancer center changed recently from Central Wisconsin Cancer Program to Agnesian Cancer Center. And here's our whole team of medical oncologists, radiation oncologists, the medical oncology team and radiation oncology team standing in front of the new sign last year. It was quite exciting. So now I'd like to talk to you a bit about the technology we have at the Cancer Center. We are blessed to have the Varian Trilogy linear accelerator. This accelerator allows us to image the patients prior to treatment. We have the capability of doing cone beam CAT scanning or KV imaging on the patient real time in the treatment room. So what this allows us to do is, after we set up the patient on our CT simulation machine, Phil and I and Tim do the treatment planning. And when we bring the patient into the room, we actually will, in this machine, which we have really all of our curative patients, we will image the patient first. So we would do another cone beam CT real time on the patient in the treatment room, in the treatment position. And we overlay the cone beam CT scan with our planning CAT scan to make sure things are aligned perfectly. And this is another picture showing the patient immobilized with the imaging cone beam CT. This is where the imaging is done, and this is actually where the radiation comes out of here, the head of the linear accelerator. So the radiation comes out of here. So these patients on this machine are imaged with the cone beam CT or KV imaging, shifted millimeters, and then the treatment's delivered. Now, one of the things that we were fortunate to have is Agnesian was the first to have the robotic table. So the robotic table just allows us also, when we're doing, after we do the cone beam CAT scanning, to make shifts, millimeter shifts in six dimensions: anterior, posterior, left, right, superior, inferior, pitch, roll, yaw. So it's a 6 degree of freedom table that allows us to, after we do the imaging, allows us to shift the patient properly. So we're setting up and treating the areas we should be treating and trying to minimize treatment to normal tissue. Here again is a nice picture of the Protura 6 degree of freedom robotic couch. And this is a pictorial showing the Protura robotic couch, showing the 6 degrees of freedom, we can rotate the couch with the patient lying on it. So now I would like to show you some pictures, and I'll try to explain them, of some of the elaborate treatment planning that we have at the Agnesian Cancer Center in the radiation therapy department. I'll give you a few examples of some common sites and some common tumors and the treatment planning we use to treat the tumor and minimize treatment to normal tissue. This first patient is a prostate patient. So we do a CT simulation treatment planning session first on our patients. And then after that, Phil and Tim, our physicist and physicist assistant, will do the treatment planning with me. And then we come up with elaborate treatment plans to treat the tumor and try to minimize treatment of normal tissue. This is a intensity modulated radiation therapy plan, or IMRT, where you can see here we are able to wrap a tight dose right around the tumor. This is the prostate gland. This is the left femur. This is the right femur. This is the rectum. This is the high dose area, and the dose falls off rapidly. So we're able to wrap the dose around the prostate gland and minimize treatment to the rectum, left hip, and right hip. This is the patient's front. This is the patient's back. We're cutting the patient like a sandwich, like this, and looking down the patient. This is a sagittal view. So this is cutting a patient like a sandwich like this and looking sideways at the patient. Because this is the patient's front, this is the patient's back, this is the patient's top, this is the patient's bottom. And here again is a nice, a beautiful image showing how Phil and Tim helped me wrap the high dose area around the prostate gland and spare the rectum and spare the bladder. The high dose area is here, and the dose falls off rapidly towards the rectum, and we're able to spare the urethra also. And this is another picture showing the Protora couch, showing the cone beam CT imaging, and showing the overlay of the contours and how we overlay the contours to make sure the patient. So after we take a cone beam CT, we overlay the contours from the CT simulation and make millimeter adjustments using the robotic couch to make sure we're set up just right and hit the cancer and minimize treatment to normal tissue. In our prostate patients, we also use fiducial markers. This is a fiducial marker which is placed inside the prostate gland, which also allows us to pinpoint the prostate gland even a bit better with our cone beam CT. This image you're seeing here is a CT simulation or treatment planning image I did on a patient in the CT sim. So that's why it looks so nice with contrast in the bladder and contrast in urethra. When you get to the cone beam CT on the treatment machine, it is very, very helpful to have a fiducial marker so we can, so allows us to make precise millimeter adjustments on a daily basis. Here's another pelvic case I wanted to present. This is a patient with a locally advanced rectal cancer. You can see the rectal tumor outlined here in red. It's a posterior rectal tumor. And this is the patient's back. This is the patient's front. This is the patient's left. This is the patient's right. And this is, again, cutting the patient like a sandwich, looking down on the patient. And you can see with our treatment planning system how we're able to wrap the high dose area around the tumor. And here also is another demonstration of the rectal cancer. You can clearly see, I use a lot of contrast and air in some of these cases. So you can clearly see by using air and contrast how the tumor sticks out like a sore thumb on the CT simulation scan. And this is the patient's back, this is the patient's front, this is the patient's top, this is the patient's bottom, looking at the patient sideways. And this is a coronal view where we're cutting the patient from the front and looking at the patient as though we're looking at them straight on from the front, and again showing the rectal tumor outlined nicely with a combination of air and contrast and how we can wrap the radiation around the tumor. Now, I would like to talk about some exciting things also that we have at the Agnesian Cancer Center. I brought some show and tell items. For our curative brain curative head and neck cases, we use a lot of immobilization. We use customized aquaplast masks to immobilize the patient on the table. So this is a customized aquaplast mask that has not been used. So what we do is during the CT simulation, we warm this up. Well, actually, I should say our therapists warm this up for me and help me, after we warm it up, we place it over the patient's face and head and make a perfect mask to help immobilize the patient on a daily basis. We do this for all of our curative brain patients and our head and neck patients. For our brain patients, we have short masks. For some of our head and neck patients, we have longer masks where we immobilize not only the head, the face, the neck, but even the shoulders. So I just want to pass this around so that you can see the type of immobilization we have, and it really helps make the treatment more precise and more reproducible on a daily basis. Thanks. So we used a mask on this patient. This is a pleasant man who unfortunately has a single brain metastasis. So this patient we treated with stereotactic radiosurgery. Stereotactic radiosurgery is a concept where instead of giving lower doses per treatment, you give a high dose per treatment on a single day. So this requires intense immobilization, intense physics support from Phil and Tim, creating a real customized plan to treat the tumor very tightly and minimize treatment of normal tissue because we're giving a very large dose, typically about 10 to 15 times what we do on a normal treatment. So you can see here, this is again a transverse view cutting the patient's head, and this is the front, this is the left, this is the right, this is the back, looking down. And what Phil and I did was fuse the MRI scan to the CT planning scan, creating a volume. And you can see this is the high dose area here, where we wrap the high dose area right around the tumor, and you can see how the dose rapidly falls off, so we're sparing a lot of normal brain. This is a sagittal view. This is the front, this is the back, this is the top, this is the bottom. And here again, we fuse the MRI planning scan to our CT planning scan. Here again is the tumor volume, and you can see how we wrap the high dose radiation curve right around the tumor and able to spare normal tissue with the dose rapidly falling off, able to spare the normal brain. And this is a coronal view showing the same patient. This is the top, this is the left, this is the right, this is the bottom. Showing the tumor here in blue and showing how we wrap the high dose area around the tumor and minimize treatment to the normal brain in that view. Now, the next case I'd like to present is we again would use a mask like that, but instead of a short mask, we would use a long mask where we would put a mask, create a immobilization device over the patient's face, neck, and shoulders to immobilize the patient, because this is a locally advanced base of tongue case with lymph node involvement. So we're treating, unfortunately, a very long area, a very extensive area, because these base of tongue tumors can recur locally, but they have a high risk of recurring regionally also within the lymph nodes. So this is kind of complicated, but I'll try to summarize it. This is, again, another CAT scan. This is the patient's front. This is the patient's back. This is the patient's left. This is the patient's right. So what we did on this particular case is we fused a PET scan to the CT planning scan, and we created a nice plan wrapping the high dose area around the tumor, which is right here, and trying to minimize normal structures. It's very important in head and neck cancer patients to try to minimize normal structures. So we're able to spare the right parotid gland, which produces saliva, trying to spare the dryness of the mouth. And with this plan, we're able to spare the oral cavity. The dentition is here, you can see the teeth, and trying to spare the oral cavity as much as possible. Here's another picture lower down showing the high dose area and how we're trying to spare the oral cavity. Here's a very nice picture showing a coronal view. Again, this is the patient's top, bottom, left, right, showing how we can spare the spinal cord. This is the high dose area. This area we're treating prophylactically. And this is a wonderful view, a sagittal view, showing the same patient, same treatment, showing the front, back, top, bottom, showing how we can wrap the high dose area around the base of the tongue and prophylactically treat the other areas, and how we're sparing the lips, the oral cavity, the teeth, trying to spare the spinal cord as much as possible. So really the elaborate IMRT treatment planning we're using on this patient. We use the elaborate IMRT treatment planning with the cone beam CT scanning every day to help deliver this type of precise treatment every day. So I just have another two cases to go through. I'll kind of fly through here. This is another brain case, and this unfortunate patient has an high-grade astrocytoma, where here's the tumor, subtotally resected, and unfortunately she has a glioblastoma multiforme, so it's not unusual for these tumors to have to be multifocal. And this shows how we can wrap the dose around the tumor and minimize treatment to the normal brain. I want to get to this case because this is a very interesting case. This is a patient who had lung cancer, was treated a number of years ago, and actually had a left pneumonectomy for locally advanced lung cancer a number of years ago. He only has his right lung. So this is a very tough clinical situation where this patient has a T1. He then developed a small non-small cell lung cancer in the right lung. He only has one lung. His left lung is gone, so his pulmonary capacity is limited. So again, the patient saw Dr. Lilly. Dr. Lilly was concerned about doing surgery because the patient only has one lung. So this kind of shows the technology we have at the cancer center. We did a stereotactic body radiation therapy on him. So again, in this particular case, we're able to give a high dose of radiation. In this particular case, we gave 3 high doses instead of 6 weeks of radiation. So we're able to give a high dose of radiation and wrap the high dose right around the tumor. Excuse me. Able to wrap the high dose right around the tumor and minimize treatment to his normal lung, because his lung function is critical because he only has one lung. And again, this is a sagittal view showing how we can wrap the high dose around the tumor and spare normal lung. We also have a lot of other really fancy planning capabilities. We have a 4D CT sim where we're able to watch the lung move and the lung tumor move on inspiration and expiration. And I don't have time to get into that, but you can see how our ITV is larger, how we can actually watch a tumor move and make sure we're hitting the tumor and minimizing treatment of normal critical structures. And this is a coronal view showing the lung tumor and how we're able to wrap the high dose area around the stereotactic body radiation therapy. I'd like to present this last case quite quickly. I know I'm running out of time. This is another interesting case This is a head of the pancreas tumor. So this is the CT simulation scan where I use contrast in the stomach and small bowel. So you can see the stomach and the small intestine, the duodenal loop. You can see the left kidney, right kidney, liver. And this patient had a stent in the common bile duct. So this stent was very helpful for the treatment planning, but also very helpful for the daily cone beam CT imaging that we do on our radiation, for radiation on a daily basis on the Trilogy. So this is a transverse view showing the patient's front, left, right, back, showing the stent in the common bile duct, and showing how with IMRT we can tightly wrap the dose around the tumor and minimize treatment to the kidneys, liver, stomach. This is a wonderful coronal view showing the same patient with a stent in the common bile duct and how we're able to wrap the high dose area with IMRT around the tumor and spare the liver and other normal critical structures. And this finally is a sagittal view showing the stent in the common bile duct and also showing how we can wrap the high dose area around the tumor and spare the liver and normal structures. I apologize, I went through a lot of information quite quickly, but I just mainly wanted to show you, number one, just show you the wonderful technology we have at the Cancer Center to deliver really state-of-the-art radiation therapy treatment as far as IMRT, three-dimensional treatment planning, and stereotactic radiation therapy, but also to show you the quality imaging we can do on a daily basis on how we can align patients precisely on a daily basis to deliver radiation therapy. Thank you so much for allowing me to speak, and if you have any other questions, feel free to call myself or any of my staff at the Cancer Center. We're always willing to help and help any of your patients. Thank you.
That's a tall order to follow, isn't it? Radiation, medical oncology, number 2. So, I'm a medical oncologist. As many of you know, I used to be an internist, went back into training and changed to medical oncology. So when I was asked to do this discussion, I thought, wow, this is going to be difficult because, quite frankly, my field is expanding immensely every day. Almost you can't turn on the news and hear something about this. So I thought, how can I like to present stories when I give talks, and I thought, how can I do that? How can I present a good story that will try to help you understand some of the advances that were occurring? And it's very difficult because a couple of things. Number one, when my kids come and see me, they always go look at Dr. Vander Kooy's stuff and say, Dad, that's really cool. Why do you do something so boring? You just give drugs. So I thought, I can't bring a bunch of slides to show cool things. Dr. Vander Kooy is going to do that. So keeping that in mind, I thought, how can we tell this? So first of all, this is Dr. Lundberg and myself. Dr. Lundberg is my senior partner, and then myself, of course. We have 2 medical oncologists. This is our staff. On the left, your left, is Sarah. It's Dr. Lundberg's nurse. Betsy is my nurse. She's over here somewhere. Rachel is one of our additional nurses. I'm going to quickly go through. These are our ancillary staffs. Basically, we have nurses that are specially trained to give chemotherapy. So all of our nursing staff, that give chemotherapy have been specially trained both to give the medication, to understand side effects, and to help patients. But they've had additional training and certification. So we have several nurses, Nikki, Margot, Terry, I'm sure all of you have seen or know, Kristen, Cindy. We also, over at the Cancer Center, have dedicated pharmacists. This is very helpful both for Dr. Lundberg and myself, but also patients. So we have Travis, who's a pharmacist, and Patty, who's a pharmacy technician. Basically, when we order medications at the Cancer Center, our pharmacists mix all of our drugs right in-house. And so it's very helpful to have Travis and Patty available. Patients, if they have questions, can actually ask the pharmacist. Travis does quite a bit of teaching himself. and then all the additional staff that Dr. Lundberg showed you that we have access to over at the Cancer Center. So as I said, when I give a talk, I try to give a story. And just interestingly, I was called and said, do you want to bring any props? And I thought, oh, wow, look at that. Dr. Vander Kooy gets to bring these cool props. But who would want to see a pill box and an IV bag? So that doesn't work for me. But so I thought, let's tell a story. And basically, the thing we're going to eventually get to is targeted cancer therapy. I'm going to explain what that is, but what I would tell you is that when you hear on the news at night some of the new cancer developments, almost always we're talking about targeted cancer therapy. These are very specific treatments. And what I thought, rather than just telling you about some of those, is tell you how cancer begins, how cancer is very heterogeneous, and hopefully help to understand some things about targeted cancer therapy. So this is the science lecture today. I'm going to talk about what is cancer. So this is a situation here which we've probably all heard of. On the left-hand side here, your left-hand side, this is a normal mole. I mean, goodness, many of us have tons of these. As we get older, we tend to get more. This, however, is a melanoma, clearly different. A little bit of teaching, we talk about the ABCDs of melanoma. Just quickly to point out what they mean. A, if you cut this guy in half, split it over, it would look the same from one side to the other, wouldn't it? How about that melanoma? If you cut it in half, would it look the same one side to the other? No. Sign of melanoma, asymmetry. B, borders irregular. See how that guy looks like he's very irregular? This is very smooth. B, border irregularity, another sign of melanoma. C, color variegation. I don't know if it came through very well, but in my original slide, it's very variable in color. There's some lighter areas of black, some darker areas of pigment. But C, color variegation. D is another one, diameter bigger than a pencil eraser. So that's melanoma. But what has happened? Well, a couple of things. Cancer is a genetic disease. What do I mean by that? It develops from a series of predictable sequences. So one of the first things that I have patients often tell me is that we're all born with cancer. Wrong. There are babies occasionally born with cancer, but most situations, we're not born with cancer, we develop it. So that's kind of a thing that I have patients often tell me, is that we're all born with cancer. Wrong. We may develop cancer. Basically, cancer, or the formation of cancer, is called carcinogenesis. Just like from the Bible, Genesis, the beginning of cancer occurs when a normal cell transforms. It occurs by this step-for-step transformation, and it involves an abnormal change in the cell's DNA. What's DNA? Well, I tell my patients that DNA is kind of the Morse code of the cell. So just like Morse code, bleeps and dash, eventually ends up for a message from somebody, in the cell, DNA is the Morse code of the cell. It tells the cell exactly what to do and how to behave and be normal. What happens in cancer, just like if you change the bleep and dash in Morse code, to somebody who would understand what that means, if you change the bleep and dash, it might change the whole message. In cancer, what happens is there's a change in the cell DNA. And that causes that cell to most commonly produce new products which allow that cell to not be controlled. That's all that cancer is, a change in the cell's DNA which allows it to not behave. So, change in the DNA. That DNA, if you've ever heard the term, change, is called a mutation. So cancer involves mutations of the cell's DNA. These mutations facilitate the cell to be able to divide, invade, and spread, which is independent of normal cell controls. But it even gets more complicated than that. Because we talk about mutations, but what happens most commonly in cancer cells is it's not just one. It is multiple mutations. And that multiple mutations are generally required for cancer to grow, divide, and spread. Few cancers are caused by a single mutation, and we're going to talk about one of those. Most cancers are caused by multiple mutations. And even if we all had breast cancer in this room, what we find is that many of us, the mutations are different. So the only similarity may be the name, breast cancer. but our mutations could be totally different in each one of us. And those different mutations allow that cell or that cancer to behave very differently in each one of us. So this picture is just kind of showing you that a normal cell develops a mutation, and that may not cause a single problem, just may cause the cells to grow. But over time, those cells may obtain multiple other and progressive mutations, and finally, that cell develops enough mutations which allows it to do basically grow, divide, spread, and that's what leads to this problem. So just another picture to show you, cancer cells develop multiple mutations which allow it to do, unfortunately, what it does. So I tell people, my liver sits right here, and it does what it does. So liver cells are here, heart cells are here. My liver is organized into tissues, which are organized into an organ, the same for my heart. But my liver doesn't spread and end up in my toe. My heart doesn't spread and end up in my leg. The reason is because those cells listen to its partners, adjacent cells, and stay there. And they do what the liver is supposed to do. It doesn't spread. Occasionally, though, liver cells can spread. They can move down to my left toe. But interesting things happen. If that liver cell breaks off, gets into my bloodstream, ends up in my toe, it's in a foreign place. It can't live there. Several things happen. That liver cell, it's kind of like me going to Moscow saying, can you speak Russian? No, I'm in trouble. If that liver cell ends up in my toe, unless it has the ability to survive there, basically it begins to die. And not only that, the immune system comes in and says, you're a liver cell in the toe, you don't belong there. So what happens in cancer is these multiple mutations allow that liver cell begin to grow, maybe gain access to my bloodstream, end up in my toe, where then it might have mutations that allow it to grow. But the final problem then is that the immune system doesn't recognize it. And when the immune system doesn't recognize it, now I have cancer growing in my toe that started in my liver. So it's a very complex process. So, carcinogenesis, the beginning of cancer, basically it does occur in a series of predictable steps. Triggers. I thought I would just mention a couple things about triggers. What causes cancer? Well, we know sometimes chemicals can cause cancer. Probably the most common chemical that people are aware of is tobacco. How does tobacco work? Well, it's chemicals that can cause mutations in the DNA. That then causes normal cells to transform. Radiation. What's an example of radiation? Sun. Sun can damage cells, ends up contributing to causes of melanoma. Viruses. This is fascinating. We know that certain viruses can cause changes within the cells which increase the risks of cancer. A couple of them, hepatitis B. Hepatitis B virus can, in some people, initiate changes within your liver that leads to liver cancer. How can we prevent that? Well, all of us in here, healthcare providers, we all probably get hepatitis B vaccine. Guess what? If you're vaccinated and it is effective, you can't get hepatitis B. Your rates of hepatitis B-induced liver cancer, very low. A really interesting new virus treatment that's come about is something called human papillomavirus. Anybody know any cancers associated with human papillomavirus? Most women here do. Cervical cancer and oropharynx. That's a new, so let's talk about cervical cancer. What we know is that human papillomavirus is very common. Probably every one of us in this room have it. But sometimes ladies develop human papillomavirus of their cervix. And whereas many times that cervix human papillomavirus just runs its course, sometimes some of that virus is incorporated into DNA of the cervical cells. And when that happens, it can start to cause that cell to develop into cancer. So ladies get a pap smear searching for that process, and if they do, they get treatments. So the amazing thing about this is now we have a vaccine against human papillomavirus, Gardasil. What does it do? Well, my kids are immunized against human papillomavirus, and by doing so, you may be able to prevent my kids from developing human papillomavirus, and for my daughter, cervical cancer. Amazing. Dr. Vander Kooy mentioned head and neck cancer. We used to think head and neck cancer is most commonly caused by people who smoke, drink, or chew tobacco, which is the case, but increasingly now almost half of all head and neck cancers are caused by human papillomavirus. Increasing trend. This is a change that is occurring. So perhaps my kids being immunized against human papillomavirus in the future will not only reduce my daughter's chance for developing cervical cancer, but my son's also penis cancer and also head and neck cancer for my kids. So those are ways that we can sometimes stop some of these triggers. Hereditary, I want to just mention, this is a real tough one. Basically, we're not born with cancer, but we can be born with genes that increase our risk for cancer. A very common one, or I shouldn't say common, but about 4 to 6% of ladies who develop breast cancer have a gene. And that gene basically increases their risk of developing cancer. It doesn't cause cancer, but every day we develop mutations. Every day our body fixes those. What happens in people who have this gene is that normally we would all fix it. Their fixing mechanism doesn't work as well. So if they develop a mutation, they may not fix it. Eventually it may lead to breast cancer or ovarian cancer. So we talked about the causes, leads to abnormal cells. The final problem that occurs is demonstrated here. So I have a malignant cell in my body. The final thing that happens is my immune system didn't recognize it. And when that doesn't happen, most often it does, and it gets rid of it. So every day I develop mutations. I'm a widget factory. Every day I develop mutations. Every day I produce abnormal widgets. What happens? My body just fixes it quickly. If I can't fix it, it destroys it. That's the immune system. When cancer evolves is when that process broke down, and that's here. So I talked about how people get cancer. Now how about the heterogeneity? Because that is a huge issue that we face. So this, if you don't know, is a Ducati motorcycle engine. Now, what I'm trying to show is this is very complex. People will say, you know, drug companies are just holding back a cure for cancer. There isn't a single thing out there that's going to cure cancer. Because this is a Ducati motorcycle engine. Which of us could, you know, have this broken part here would probably not allow this motorcycle engine to run. In cancer, there are not only multiple broken parts, but they may be different ones. Or there may be an engine that has several broken parts within it. You can't go to the motorcycle store, buy this gear, put it in, and expect to fix this motorcycle if the problem is over here. And that's one of the problems we face in cancer. People's cancers, you know, we could all have breast cancer, as I said before, but the only similarity is the name. It could be very different from where the abnormality is within the cell, which is causing the cancer. And that has implications in how we treat that person's cancer. So, a lot of the advances that are occurring now is beginning to understand the problems which are occurring within the cell. So this is a kind of a classic picture that we've all seen. We're just beginning to understand. We have a lot to learn about cancer, but at least more of it's becoming visible. So general cancer treatments. How does an oncologist treat cancer? Wait, whoop, sorry, I keep pushing the wrong button. Dr. Vander Kooy talked about radiation therapy. As I said, I'm the pill pusher. Okay? Chemotherapy. Chemotherapy works basically by taking advantage of the fact that cancer cells tend to grow more rapidly than normal cells. And so I give people drugs which, as a, just kind of a general rule, think about it, they're targeting the more actively dividing cells. That's how chemotherapy works. It's kind of indiscriminate. That's why maybe you lose your hair, because although your hair cells are growing a little faster, it doesn't kill them, but it slows them down, and then you lose your hair with some chemotherapies. But the thing we're trying to hope for is that those cancer cells that are growing faster are killed by the drug. These two are the newer treatments. Immunotherapy is a really cool thought. I told you before that sometimes cancer, the final step is our immune system not recognizing it. There are increasing numbers of treatments that are trying to stimulate the immune system to say, hey, that cancer cell doesn't belong. this last year and a half has seen the development of a drug called Yervoy for melanoma that is malignant. What this drug does is turns your immune system against the cancer. Kind of cool. There's drugs for that for prostate cancer. We're seeing more and more of these things come to the market. The big thing which almost everybody hears about on the news is right here, targeted therapies. And it creates a lot of news, but also it creates misunderstandings. The important thing is we're going to learn about targeted therapy is it is scalpel treatment. It isn't like chemotherapy, which is boom. It is very focal. It is focal because what we are doing is identifying specific gene abnormalities which allow that cancer to grow and divide, and we try to target that abnormality with a specific drug. So I'm going to talk about two drugs. I'm going to call one a dumb cancer and smart cancer, and I don't mean any pun from that. But sometimes, and I told you this at the beginning, cancer develops occasionally when there's just a single mutation. That can become the Achilles heel for that cancer. I call it dumb. That cancer evolved from a single mutation. Unfortunately, most cancer develops from multiple mutations. It has multiple Achilles heels. So we have to try to target all of those Achilles heels. I'm going to talk now about two cancers. Leukemia, which is what we're going to talk about the story of BCR-ABL and a specific type of leukemia called chronic myelogenous leukemia. You take a drop of our blood, put it on a glass slide, and look at it under a microscope. This is what we're going to see. This is a normal person's blood. These are red cell. These little dots here are platelets. This in the middle is a white cell. This is a monocyte. This is a patient with leukemia. Now, although they're different colors, we can obviously see something is different. These things here are the red cells, but the thing that Mike and I learned in pathology is blue is bad. A lot of blue is really bad. So these blue cells are the leukemic cells, okay? You can clearly see the difference here. So this is leukemia, and if you get good at looking at these, you can kind of figure out what type of leukemia. There's lots of different types of leukemias. This turns out to be chronic myelogenous leukemia. Why is this a dumb cancer? Because if every one of us have chronic myelogenous leukemia, we all have the same genetic abnormality, and that is very unique in cancer. It's kind of a fascinating set. We have 46 chromosomes, 23 from mom, 23 from dad. What happens in this disease is a portion of one chromosome switches with another chromosome. We call that translocation. So chromosome 9 and 22 flip each other. So if we have this cancer, every one of us have that abnormality. It's how I can diagnose this. You see this? I just check the cells for this abnormality, and if they have it, bingo, diagnosis CML. So how do we exploit that? So let's contrast that to one of the tumors that Mike talked about, which was glioblastoma, which is a brain tumor. This is a very complex slide, but it just is going to show the point. On the left-hand side here are a bunch of chromosome changes. On the right-hand side is a bunch of patients. What we did, this is patient 17, this is patient 11 across the top. What we have done in these patients is looked within their DNA to try to find their mutations. In this person, 17, we can't even find one. As we go to the right, we're seeing patient 11. Look how abnormal their genes are. What does this mean? This is a very all of these people have glioblastoma, but they're very different. This person has hardly any mutations, but enough to cause glioblastoma. This person has multiple. The implications, that tumor is going to behave very differently for each one of us. So one treatment may work very effectively for you because maybe it's targeting this mutation right here. In me, I may have one of all of these. My treatments may not be very effective at all. That's how different mutations can change how we treat the disease and how the disease responds. So back to the CML, single mutation, dumb cancer. What happens? Well, it's kind of interesting. To try to tell you, a white cell has a certain number of days that it can live. So I tell people we produce white cells today, they live in our body, and they just are used and they die. So basically think of a house. 10 people in the front door, 10 people out the back door. Nothing changes. There's only a certain number of people in the house. What happens with this disease is these cells create a cancer protein. And that cancer protein is basically a fountain of youth for the cell. The cell can't die. So what happens is these cells begin to, because they don't die in 5 to 7 days, they stick around for 10 and 12 days, and pretty soon we begin to accumulate these cells, and that's why you see on the peripheral blood smear so many white cells, and that's what gets the patient in trouble. So these have become immortalized cells. They won't die like they should. So somebody at Pfizer came up with and it's all because this cancer protein, one gene, one protein. Somebody at Pfizer came up with a great idea. What if you make that cancer protein not work? And that's what this drug does. Imatinib, Gleevec, discovered about 15, 20 years ago. We give it to patients who have CML. What it does is it turns off this cancer protein. What it does is it makes those cancer cells now live normally. And by living normally, this is what happens. This is called the miracle drug of the century. And the reason is right here. I was born in 1965. If I would develop CML in 1965, this was a terrible disease. The average patient would live 3 years. 1965, we came up with a little bit better drugs, chemotherapy. That got a little bit better. In 2000, if I was diagnosed with CML and I received standard chemotherapy, things were better. My average life expectancy would be 6 years. What happened with Gleevec? Right here. This is amazing. People now given Gleevec, if we give them this drug, now some of these people have been on this drug 10 to 15 years, 93% of these patients are still alive 12 years later. What does that mean? The average age of diagnosis of patients with CML is 50 to 65. We have turned a very lethal cancer into basically a chronic disease, like diabetes. I'm 60 years old, I can't necessarily cure my diabetes, but you try to manage it. We have turned this disease into a chronic disease that people can now live out their lives. That's why this is the miracle drug of the century. If I'm diagnosed with CML today, I get put on one of these drugs. Quite frankly, I'm not too worried. I wish everything. Yep.
Do they have to go, does that treatment then last for?
Great question. Great question. I meant to say that. So what do we do with those patients? Those patients are on that drug for the rest of their lives. Unfortunately, we're not fixing their gene problem. If you stop the drug, that gene produces the protein and their disease comes back. So these people have to take that drug for the rest of their life. But that's what diabetics do. They take drugs for the rest of their life. So our goal, and Mike's goal, and my goal in cancer is sometimes I can't cure patients. That's what our primary goal is, and I tell people that, to cure you. If we can't cure you, if you have a disease that's not curable, what we're trying to do is turn it into a chronic disease that allows you to live longer and better and live out your life. This is an example of a disease that's been done. This is an example of targeted therapy, scalpel therapy, gene abnormality, protein abnormality, specific drug treatment for that. It's incredible science. I wish all cancer was the same. I'm going to give you an example of one that is not, which most are not, melanoma. Best way to avoid melanoma. This is a terrible thing. It's a bad problem. This is a complex slide, I know. The only message I'm trying to show you is that we talked about DNA and mutations in that glioblastoma where there are a lot of them. Sometimes what we do now is on the left-hand side, I'm just going to show you different proteins. And what we see here is that in patients who have melanoma, certain proteins are mutated more frequently than others. This big red here is that 65% of patients with melanoma have a mutation called BRAF. Okay? This one, whatever that is, I can't read, 8%. So some mutations are more common than others in patients who have melanoma. BRAF is one. So guess what happened? What does BRAF do? Well, BRAF is a protein that tells the cell to grow. We need it. We all need it. What happens in cancer is that BRAF gene abnormality now is turned on excessively. And what does that do? This melanoma cell now begins to grow uncontrolled. But I also wanted to point this out. So here it is, the abnormal BRAF, but also there are other things that are telling the cancer cell to grow, or potentially other things. So somebody at a company came up with an idea of creating a BRAF inhibitor, and that inhibitor is right here. When drugs are in early development, we don't call them anything except give them a number. So this was PLX 4032. It was given to people and found out it worked, and so now it's called vemurafenib. About a year and a half ago, this was in the news. This was huge news. It was in the USA Today. It was in every news program at night, how we're going to alter melanoma treatment. Basically what it does, turns this protein off. This is an example of a patient given vemurafenib. This is a PET scan. PET scans are taking radioactive blood sugar, and basically cancer is growing, and it uses glucose to grow. So we're able to tag that cancer with radioactivity. This is a patient who has metastatic melanoma. Basically, melanoma has spread throughout their body. All of these black spots, unfortunately, are cancer spots. We put this patient on vemurafenib. 14 days later, we do a PET scan. Amazing. This cancer has been turned off with this drug. I'd like to say that these areas are normal, just to point out, that's why they're not. These are kidneys, this is bladder, this is brain. But you can tell there's a big difference. So this drug for this patient has been an incredible finding for them. How does this, portend into outcomes for patients? Unfortunately, the problem with melanoma is, I told you there's one pathway, but many times there's multiple other pathways that are driving the cancer cell. But at least we have helped. The goal will be to find more and more drugs, potentially, that can begin to turn the cancer off. This is the difficulty we have in patients who have cancer with multiple mutations, is we're able to slow this cancer down, but unfortunately, this is measured in months, not in years like the other patient. So, I wanted to come back to your analogy of carrots and beans. It's going to be hard. People always say, how can you do what you do? I can do what I do because every day I see many of my patients like coffee beans. When the process starts with them, unfortunately with their cancer, there's a lot of eggs, there's a lot of carrots. But I think every patient who has cancer, they begin to see things differently. And for me, that's a very incredible human process to see evolve in patients. So I tend to think of my patients as coffee beans. So thank you. My son sent me this. I don't know if I should say this, but he said this is a redneck high-rise apartment complex. I don't know about that. I thought perhaps this is a northern Wisconsin tree stand. Deer hunting. Thank you.
That's great. Thank you. Thank you, Dr. Jones. Thank you, Dr. Vander Kooy. What a great presentation. I could listen to you all day. I'm sure there's more.
So the question is, what causes one person's immune system to recognize cancer and another person's not? The answer is, that's one of the great mysteries of oncology. Why that does and why it doesn't. Suffice it to say, it's not a very good answer for you, but it happens. I can't give you, because we don't know why that happens. Immune surveillance of cancer is very important, and as I said, it happens every day in every one of us. But occasionally it doesn't work, and probably the most profound statement would be that the process isn't perfect, but it's 99.99999% perfect, but occasionally isn't. Interestingly, some patients have immune diseases. So let's just say the most common immune disease we hear of, HIV. HIV is an immune surveillance disease problem. They actually have higher rates of cancer. So there may be a lot of things that contribute to why our body doesn't recognize these. Sometimes immunosuppressives do. So basically, I can't give you one good answer. Great question. So, Dr. Vander Kooy? The question is, what makes us determine whether we're going to use radiation or chemotherapy?
That's a really interesting question, and it really depends on the disease site. Particular disease sites, radiation can be used in many ways. Radiation can be used as a primary treatment to treat the primary cancers, such as prostate cancer, where it can be an alternative to surgery. Radiation can be delivered preoperatively, such as that rectal cancer patient I presented, where you can use it in combination with chemotherapy to make the tumor more resectable, and so the surgeon can more readily resect the tumor. Radiation can be delivered in the postoperative or adjuvant setting, such as in breast cancer, where a lump or lumpectomy, a lump of tumor is removed, and use radiation postoperatively to reduce the risk of recurrence. Radiation can be used in the palliative setting for pain control or symptom control, such as in the metastatic case, where radiation is used to help someone with bone metastasis to help their pain, someone with brain metastasis to relieve their central nervous system symptoms. So, radiation can be used in all those settings. Radiation can also be used in some benign settings, such as prevention of heterotopic ossification, which you sometimes see in patients who have who've had trauma, who've had a hip replacement. Radiation can be used in prevention of keloid. So, radiation can be used in so many different ways. The exciting thing, though, I've been in radiation oncology over 19 years. The exciting thing is how we've improved the cure rates in malignancies, combining radiation therapy many times with chemotherapy in some disease sites. Again, radiation can be used in many different ways.
Yes?
I have a question. If you had a family member where all siblings have had cancer of some type or other, and their parents' cancer, aunts, uncles have cancer, does that put a higher risk on the children than they had? And are there tests that can be used to help determine that gene was out there?
Sure. So the question is, if there is a strong family history of cancer and maybe multiple brothers and sisters, are there tests that can be done to help determine whether perhaps either you or your children might be at risk for cancer? And the answer is sometimes. So the answer is sometimes based upon what we see in those cancers. For example, if you have a strong family history of ovarian and breast cancer, and maybe melanoma and prostate cancer and multiple brothers and sisters, that may tell us that perhaps you're one of those patients who have one of those breast cancer genes. And therefore, generally we like one of the persons with cancer to be tested to see if they had it, and if they did have this, then that lends an opportunity for other people in the family to be tested for that gene. It doesn't do us any good if you find a gene if you don't know what to do with it once you found it. But in patients who have this gene, if they were discovered to have it, it gives them an opportunity to maybe do things to reduce their risk. So the most common is a breast cancer ovarian gene. You've probably heard of it, BRCA1 and 2. It's been on the news lately because of Angelina Jolie. So in her family, she had a history of ovarian cancer. She was tested, she had the gene. She did not have cancer, but now it gives her opportunities. She knows she has the gene. It's an interesting gene. What it did, and I told you this in the beginning, is those people develop mutations, but they don't fix them as often as you and I do. So they have just a higher rate of developing cancer. So those people could perhaps have what we call risk reduction breast removal, risk reduction ovarian and fallopian tube removal, and that can dramatically reduce their chance of developing, obviously, cancer, but more importantly, dying of those cancers. There are certain colon cancers, too, that we can, if you see a strong family history of colon cancer, that we can perhaps check. So that's why I say it kind of depends on what the cancer is. Sometimes you see very just sporadic cancers. That's a really hard one. There's probably something in them, but we don't have the way to test for it. I just wanted to mention, and I forgot to because I had so much to say, the best way that you can treat cancer is to prevent it. And the ways you can prevent it, Mike and I, 2/3 of our breast cancers are stage 1. That's the same across the country. The reason, early detection, ladies with mammograms, colonoscopies. Everybody here above age 50 should have a colonoscopy. Agnesian offers this as part of your employment. Take advantage of it. I'm going to tell you a sad story. My father died of metastatic colon cancer. Why? I knew my father to go to the doctor one time in his entire life. His son was a doctor and a cancer doctor. I could not get him to do something. I could not get him to go do a colonoscopy. His thought of a doctor was, I go when I'm sick. Wrong. Go for prevention. Everybody should have colon cancer. No one should really die of this disease like my father did. Go, have your colonoscopy. So the best way to treat cancer is never to get it. Early detection is very important. That's an example where perhaps you can be tested, but it depends. That's a winded answer. Woo.